morning, everyone. Welcome to this part 2 of this month's Town Hall series. We thank you again for joining us. We are going to be speaking with Amy O'Malley, who is joining us today. She is a pediatric physical therapist. I will let Dr. Havert introduce her since she knows her much better. We are excited to have you join us. Hopefully this will give you some good information either for your own kids or for family or grandkids, or maybe you were just curious in general about the topic. So it should be a fun topic to cover. Just a few kind of details or things to remember about the talk today. We do want you to feel free to ask questions. The best way to do that is to look at the Q&A box and then go ahead and type your questions. We will be keeping an eye on that. And then we're going to save some time towards the end of the talk to go through those with Dr. O'Malley. The other thing is Dr. O'Malley is, of course, a pediatric physical therapist. She is a clinician, but this talk is not a replacement for clinical advice. So we always want to make sure that if you do have concerns that you bring them up to your doctor and seek additional advice, okay? This is meant as a kind of overview and general guidance. So I will go ahead and pass this over to Dr. Howard for a better and formal introduction to Dr. O'Malley.
Hi, it's Dr. Cecily Havert. If you guys haven't met me or seen me on previous town halls, I'm very, very excited to be welcoming Dr. Amy O'Malley. I'm going to try to keep my introduction short because I could probably make this really, really long because Amy and I have known each other for a long time. I actually met Amy as she was the clinician to my son, actually, when he was 2.5, right, Amy? I think that's when you started working with him. Yeah. So that's how I met Amy, and she worked with him for about 2 years, discharged him, and very quickly, Amy and I decided that we needed to become very good friends, which we did, and we've known each other for this whole time. My son, just to give a little bit of context, my son is now 16, so that was about 14 years ago. So been honored to know Amy as a friend and also as a colleague during this time. A little bit more specific as far as what Amy's training has been like. She is a practicing physical therapist. She's been doing this since 1998. Exclusively in pediatrics. And she joined Good Beginnings, which is the practice that she's at right now, in 2004. And there she serves as the director of operations in addition to treating patients. Amy has a special interest, which is what she's going to be talking about this evening, a very special interest in pediatric incontinence. And she's also developed a program at Good Beginnings to help children gain control of their bowel and bladder challenges via small muscle activation, breathing exercises, and core exercises. And I think that these are also, exercises and techniques that adults can use. However, this evening we will be discussing primarily the pediatric population. So without further ado, I'm going to let Amy take it over.
Thank you, Christy and Ceci, and thank you for such a wonderful introduction. I love Northern Virginia family practice. I feel like I've known Ceci forever, but I also know all the other doctors at NVFP and really enjoy working with all of you. And I'm really excited that you brought someone on who can really blend the whole family at this point, and that we're going to start sharing our topics together. So thanks for this opportunity. Reading that description makes me realize we have to also expand the description of our program, our bowel and bladder program, because it's become much more comprehensive in the last couple of years than it was originally. And we're going to talk a little bit about that today. I have slides for you all, so I'm going to put the slides up in a minute, and then we will talk through those. And like they mentioned, we will have time for questions at the end. What I would like is if there's questions about things that I'm speaking about that needs clarification in the moment, please go ahead and drop those right in the Q&A and say, maybe with a hand up and say, time sensitive or, in the moment. And then the doctors can interrupt me to tell me if it's a different question or a more gestalt question at the end, we will talk about those things. There's plenty of time for that. So, okay, without further ado, let me share my screens. Okay, so making sure everything looks okay. So I get this talk a lot, although I modified it for this group. because I really wanted to talk about incontinence issues and general toilet training readiness. Usually I only pick one or the other, but I figured we could handle both in the same day. And so we call this as part of our potty talk series, just to give it a little levity, because you know what, who are we kidding? Bowel and bladder things need a little levity, especially when you're working with kids. The only way we're going to make it happen. Okay, so you're part of our potty talk series. Good Beginnings is a pediatric PT and OT practice that has established since 1989. Again, as Dr. Havert mentioned, I've been there since 2004. And we have locations in Falls Church and Herndon, Virginia. We're a really well-established practice, and we do lots of specialty programming in addition to regular pediatric PT and OT. Okay. And hello. So it wants me to use this fancy little arrow today. So in general, there's so many things we could talk about, but why are we here? Why does anybody want to listen to me talk about bowel and bladder issues tonight, right? I'm figuring it's because bowel and bladder issues in children are pretty prevalent, and they have been prevalent for a while. They have been increasing in prevalence, and they have increased triple-fold since the COVID pandemic. And we can get into that a little bit along the way. It kind of, it's weaved in throughout my talk. You'll hear me referencing a lot like pre-COVID, not pre-COVID. And so it's just continuing to grow is what we're finding. And so we're seeing more and more kids. I could literally run a full-time practice just doing this. We're not ready right now, but that we could at this point. And right now, to our knowledge, Good Beginnings is the only other program in the area outside of Children's Hospital. We are the only one approaching our intervention the way that we do, which again, you'll learn more details about. We do know some other clinics have been trying to develop their programs, and I hope they do, because there's so many people who need us, but we're the only one that we know of right now. So this is what we talk about a lot. So let's start with defining what are bowel and bladder issues. And these are the main ones. There's always other things as well, but this is what the bulk of people are going to come to us for. Constipation, number one issue. We're going to talk a lot more about that. Something called encoparesis, which is the involuntary release of poop when you don't want it. Again, we're going to get into all of these more. Anything related to improper bladder activation, and that could be too much, too little, intermittent, daytime, nighttime. There's a whole separate category for those. Recurrent UTIs, and I label those separately because they end up leading to improper bladder activation and often other things. And they're the tidbit that I want any parent of a young child to keep in mind, that if you're getting recurrent UTIs, we need to talk. Like, we either need to talk to your pediatrician, and then we need to potentially loop someone in who may guide you to what may come of that, because I see a lot of, especially young women, who have had the big flag in their history as recurrent UTIs as they were younger, and then how their urinary system adapts to that stress along the way. And so that is just a tidbit that typically falls under bladder activation, but I want you to keep that in the back of your head. And then really the last biggest one, it's kind of my two big ones are bookending it, is the delayed onset or successive toilet training. That has just gotten much harder for people, especially since the COVID pandemic, and we are going to talk about why. But I just wanted to give you a list to start with, and then we're going to look a little deeper. Let's make sure that we're all on the same page with what these terms mean and why they might be important. So the first one is constipation, which is infrequent bowel movements or difficult passage of stools that persists for several weeks or longer. Okay, and we've all been there. We've all like traveled or had a weekend of fun food and you know, had some challenges. That's not chronic constipation. That's just adapting to your daily life. What we do need to worry about is something that is 4 times a week that lasts for several weeks or longer. Okay, especially the infrequency of bowel movements. I have a lot of people who come in to say, well, I spoke to Dr. A or Dr. B about it. My child only goes once a week. It seems to be okay. When you talk to more incontinence-based people or people from the developmental perspective in young kids, we find that not to be okay. It leads to a whole host of other issues. Okay. When we talk about constipation, we're talking about at any age and even with infants. And I actually do have a whole infant program that I do to get them to not have long-term issues with constipation. I would rather meet infants that are not pooping more than once or twice a week while they are infants, so it doesn't develop into a toddler and older issue. And I recently had a family that I worked with. I ran into them at something else, another community thing. And they were there for some other reason, and we thought we knew each other, and then we recognized each other. And they said, "Oh, do you remember, now that we're not wearing masks, you can see us. I came to see you because I was worried about my baby. And we had one follow-up session and she's fine based on what you did for us." And that would have taken, what we would have had to do as a 3 and 4-year-old would have taken months. So it's really important that we even start to talk about constipation in as young as infants who are weaning off of breast milk. One of the other important things to talk about with constipation is that functional constipation, which means there's no organic cause. It's not because there's a medical issue or an issue with your anatomy or something like that. It's just something in the way your system is processing things is not letting you poop every day, is occurring in 18.5% of toddlers and children, and then 14% in adolescents. Okay, that's nearly 1/5 of our kids, and that was in 2018. Again, those are pre-COVID levels, which means those numbers are higher now, guaranteed. That's a lot of people. I just don't think that people need to go through this. It's not okay that we would accept this. We wouldn't accept 20% of people having heart attacks. We wouldn't accept 20% of people having A, B, or C. So this is not okay either. And that's why we're talking about it. So that's constipation. The next one is encoparesis, which again is the fancy Latin term for the repeated passing of stool, 99% of the time involuntarily, into clothing. It means it's not when you're on the toilet. It's not when you're prepared to have a bowel movement. It may not be a full bowel movement, but it is a release of fecal matter, usually into your clothes. Colloquially, this is known as smears or shards or skid marks. And many times people report it to be due to improper wiping. It's very rarely due to improper wiping, but that's what people think it looks like. And it happens more than usually once throughout the day, and people would like to stop it, most often the parents who are doing the laundry. So that's how we track a lot of our progress. Okay. One of the notes about encoparesis versus constipation, you can be constipated at any time. You're not really considered having encoparesis until after you're 4 years old due to the physiological mechanisms of toilet training and a voluntary bowel control. Things can be happening in between the ages of 2 and 4 where parents are reporting, well, there's poop in the underwear, there's poop in the stool, but that may be due to not fully acquired toileting control versus a true encoparesis problem, which you're going to learn more about. So also just to keep in mind, you're going to start seeing some numbers and ages that are older than you think, that are older than you've been told, that your grandmother has told you, or your mother has told you about toilet training, because we now have more information about when we should really be expecting it. Okay. The next one is enuresis, which is the fancy Latin word for the involuntary release of urine. And again, this is considered to be true after 5 years of age. Natural physiological maturation can't be assured before then. So people who are still leaking a little bit before the age of 5, there has to be other criteria for us to consider it a true enuresis problem versus a lack of acquired maturation or an acquired skill. So keeping, again, between the ages of 4 and 5 in mind. The latest data that I found was 15% of girls and 22% of boys. Again, so we're again at, a quarter to a fifth, or a fifth, a little bit more of the population, which I just don't think is okay. We wouldn't expect that of any other medical issue. You can have enuresis that happens during the day. You can have enuresis that happens at night, which is often called bedwetting. And one of the things we'll get into a little bit, depending on how much anyone is interested, is that daytime enuresis and nighttime are two different animals. They're treated differently and have different causes. And there's wonderful new research that came out in the last 5 years that is really helping us break through with nighttime bedwetting. So we will get to that as well. Okay, so then there's a million other bladder issues. I'm just going to give you a list in case this affects you or your child or someone you know, or you just want to keep this in mind for the future. You can have everything from an overactive bladder. You can have an underactive bladder. You can have an urge incontinence where all of a sudden you have to go and you have to go now. You can have someone who postpones voiding, whether it's conscious or unconscious. You can have something called dysfunctional voiding where you start and stop and start and stop and maybe don't empty all the way. You can have general obstructions. You can have stress incontinence, which is again another, when there's a stressor, it makes you go. Like sometimes it's with laughter or jumping. You know, moms often get this after they've had the babies and they go back to exercise. You're trying to do your CrossFit, and there's all these videos that came out a while ago about CrossFit mamas who couldn't help but release urine. You can have something called giggle incontinence, which is separate from urge and stress incontinence, but it's actually a neurological issue that happens in teenage girls. And there's a wiring issue in the brain. And every time they laugh, it causes a full release of the bladder. Happens around puberty. And it is not stress or urge. It's a neurological switch that's on incorrectly. You can have something called vaginal reflux where urine gets trapped in the structures. And so you finished urinating, but then it doesn't fully empty out of your body and it gets trapped. And then when you go to stand up, it wets your pants again. Recurrent UTIs always get a shout out. And then you can have something called bowel and bladder dysfunction, which is your constipation activates your bladder incorrectly, but it's a different animal to treat than some of these other ones. And of course, there's always something different. There's extras out there, but these are the main ones you're going to see. Okay, and then this isn't really to define, but you know, again, one of our biggest problems is the delayed onset or success of toilet training. One of the number one indicators of this is emotional trauma. We're not saying that every child who's had emotional trauma can't toilet train, and we're not saying that every child having troubles with toilet training has emotional trauma, but there is a significant link that even a single emotional trauma can, at the right age, can affect your success with toilet training. Because it's a developmental skill, and things like stress and trauma do affect any developmental skill, and this is also one of them. One of the reasons is that you may have started too early, and then the child rebounds. You know, they're just not up to the full challenge of the task, and then because they're starting to become aware of it, they may rebound from that, and we've got to intervene. But oftentimes there's constipation involved, so you can't work through your constipation issues to be successful. We've got to work through that. And then many of the kids that we're starting to see nowadays are also affected by other developmental issues. Kids with sensory processing order, kids on the autism spectrum, kids with cerebral palsy, kids with other physical impairments, or just general developmental delay, which again has really increased since COVID. There's all the, I think I have it on a different slide. Everybody is delayed in COVID because of how the world had to shut down. So kids are having more developmental delays, which is again affecting the onset of toilet training and successful issues like that. Okay, so where do you start? So someone comes in, someone finds out about us. They hear they're having trouble. They find out there's this clinic. They come to the clinic. Where does one even start with this, right? What we find is that most of the children come in with more than one of the challenges. They're either constipated and they have encopresis, or they're constipated and they're having enuresis related issues, or there's some developmental issues, or. So where do we go? We start with my favorite new phrase, which is constipation is the root of all evil and most toilet challenges. There is no teaching anywhere that I have found yet over all the years that doesn't say you can start without constipation. Okay, you've got to clear constipation before you can do anything else. And I'm going to show you why. So you'll see this phrase that most practitioners will start with clearing the constipation before moving on to other issues. Why would that be? Because a single episode of constipation can cause a child to begin withholding behaviors. So withholding is when the poop comes to the exit and the child's like, can't do it. Not sure what I'm going to do about this. I'm just going to choose not to engage. Then withholding stretches out the colon, which leads to all the other issues. Then you mix in somewhere along the way, parents will call their doctors who will say you should give them Miralax, which is fine. Miralax is a big part of our day, but sometimes not to the right dosage. And then it changes the consistency of poop, which then confuses your body and it doesn't know what to do. So we're going to go through two fun images. The first one is just of the body. So just giving you a fair forewarning. What I just want to do is review, our elementary school science as to how this all works, because I find the parents at the clinic tell me this is really helpful. So we all know we eat and we chew at our mouth. We chew, break it down, and it goes down to our stomach. And then at the stomach, it gets broken down into chemical constituent components so that our body can process it. So then it goes from the stomach into the small intestine. I wish I had a laser pointer for this. Still don't know how to do laser pointers on Zoom, where it goes into the big squiggly part in the middle. And the job of that part of your body is to take out all the nutrients that we can possibly take and give it to the body for use. Then what it does is, you see where it goes from brown to light brown and to the big green colon. That's your large intestine or your colon. And the job of the colon is to take out as much liquid as possible to make it a nice, firm poop so that it can travel through this tunnel and tube and go into the rectum and come out the anus. So here's some fun that we have in the clinic. You know what? I can't see myself, so I don't know how I'm showing this. Okay. These are our mascots. These are our poop fidgets. You can buy these on Amazon too if you like them. This is Percy. This is Pippa. Girl and a boy for everything. And someone found these for me, and I've never been happier, because this is what a perfect poop looks like. There is a thing called the Bristol Poop Scale, which I did not put a slide of in here because some of you might be eating dinner and it's a bunch of poop and it's gross. And it's the rating of the consistency of poop. There's actually a standardization so that we all can speak the same language. And this is a number 4, and it's a perfect poop. It is one long tube, but it's pretty smooth. In fact, when he's really looking at the scale, it's even smoother, but it didn't look right in the fidget. And so it's one big poop, and it is supposed to go through this tube. It's supposed to form as it goes through the tube, drying out to be here. One of the important things is that it is one solid piece, so it gets pushed along as a unit, and then it comes around this curve at the bottom, and then there are 2 valves, the inner and anal sphincters, are kind of like airlocks. And I wonder if this would be better on the next slide. Oh, my image isn't open. Oh no. Very interesting. Oh, that's a bummer. Okay, I don't know. It loaded on my slides on my screen. There's an image there, but okay. So what happens is then it comes around. And then there's an airlock. There's the inner airlock and the outer airlock, and a little bit in between, just like in a spaceship or anything else. And when the big solid poop comes up to the first airlock, there is a physiological reflex in your body called the rare reflex. It's got a long name, don't worry about it. And when something pushes up against it, this inner airlock is supposed to open for a second and test it out. Is it solid? Is it gas? Or is it liquid? Okay. And then based on the results of that is what this does. So this one says, oh, it's gas. I opened it, it's gas, throws it through the chamber and lets it out. If it's a solid, it opens and says, ooh, that's a solid. Close, close, go to the bathroom, release. Okay, if it is a liquid, like when you have diarrhea or something else, all open at the same time. All hands on deck to get that stuff out. And this is why it's important when we talk about the other problems we're having. And that's the natural swing of things. And so this guy, moving around because I realize I have to demonstrate, up, around and over. Okay, but you can have constipation. Okay. So imagine this trying to go through the tube. That's not going to happen. Now imagine that this is all broken up into little chunks. Well, now you've only got one little thing going through at a time. So then your colon doesn't know what to do. Now what I'm trying to figure out is, I'm really bummed because this image is very important. Am I the only one with control right now? Or do you all have control? Can you click on that or no to open it?
We can't. Yeah, because it's on your computer.
So it's because it's on my computer. I'm trying to figure out, okay, I'm going to escape for a second. I'm going to stop the share for just 1 second because this is a real important image, y'all. Let me see if I can just pull it up. Nope, come back here. The image. And then maybe I can just, my computer should know this. Just 1 second. Perhaps are there any time sensitive questions in the chat right now?
We don't
Doctors have,
no,
there's nothing there right now?
Okay. So far, but still take your time. It's an important part of the talk. So
apologize, people.
It happens.
And I mean, I tested this last night. It's just been that kind of day. Oh, this is my favorite one. Okay, so let me go back. Now, if you are eating dinner and you don't like to look at certain images, this is going to be a schematic of food.
Disclaimer.
I'm just giving you a heads up. Okay, so let's see if I can do this. So now, let me just go back to sharing. Okay. Get ready for some fun. I live in this day by day. Okay, so then here's what happens. So again, I've taken you through the digestive tract, and now we're at the end. We've gone around the big curve, which is hard to get around, and you've got Percy or Pippa in this nice one long piece. We've got the two airlocks, and then this is your outer airlock. And you notice how it's real nice and tight. You can squeeze that sucker shut and nothing's gonna get out of there. And that's what's typical. So this is what happens when you have constipation. We get something called mega poop, which leads to a megacolon. So again, we're here, okay? And what happens is you can't get it out, and your body maybe gets little chunks out. That's where the pebbles go from. And your body just gives up and says, all right, we'll just deal with that one tomorrow. And then what happens is you can see, look at the sizes between the two. This starts to stretch out. It's very pliable material, okay? And then it just gets stuck because there's less pressure to push it out because it's just now one big stretched out rubber band, okay? And then what happens is you don't stop eating. So the job of the colon is to then take out the water so that you get a nice poop before it comes out, except now there's stuff there blocking the full absorption of the water. So you don't get poop that is as dry, and depending on how backed up you get and how constipated you are, you can get some pretty liquid stuff that's coming out of there, and it starts to stretch out everything. So your inner airlock gets stretched, your outer airlock gets stretched. This loses its push, and the whole system is thrown off. And what happens is, do you remember when I was talking about that reflex a minute ago? When you've got your airlocks, if it's air, it goes open, in, out. If it's poop, it goes open, hold on, get to the toilet, out. If it's liquid, it goes, oh my God, that must be illness. And it opens everything to come out, which means your brain, and it's a reflex. This is not something you have control over. Your brain is being told, let it out. So it wants to get that liquid poop out. And by the way, on the way, it just grabs some of the dry stuff quick. And that's how you get the mushy paste. That's one of the reasons you can get mushy paste, okay? And your body's doing everything it's supposed to do. Your child has no concept of this, and it's not at a conscious level. So they don't know what's happening, and they start to lose sensitivity. Because here's the other thing that happens. In a typical system, like, how do you know this is even happening, right? So I like to liken it to your favorite heist movie, like an art heist movie, like some kind of action adventure. Poop's coming around, it's coming down, and these are laser beams that connect from side to side. And when they're connected to each other, there's no noise. When something disrupts the signal, they start going off. Beep, 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 something's coming, be aware of it. And then in typical, it would interrupt the laser beams enough while you're testing your two airlocks to tell you what to do. And when the poop leaves, the laser beams go back to being quiet. Well, what do you think the laser beams are doing when this stuff is stuck here, right? So it's beep, 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 while your kid's also physically uncomfortable. After a while, they just have to tune that signal out, right? So now you're getting stuff that's stretched out, you're getting liquid stool that they can't feel. This has lost its tension, and they stop listening to when their body tells them new things are coming because they can't handle the noise all the time. And so it becomes a real chronic problem. It takes 7 times as long to shrink your colon back down, at least, than it does to stretch it back out. So it doesn't take long to make it a problem, and it takes a lot longer to fix it. And I know this was a lot about poop, but this is just a really important concept, that there are so many things that go into it. And if you've noticed, not once have I said it's because your child doesn't want to go, okay? The other number one, I say number one a lot, but one of the top things I hear from parents is, well, he's just choosing not to go. Well, okay, potentially he's truly choosing not to go. He's choosing not to go because it's either hurt, or it feels uncomfortable, or it feels squishy and weird, or his signal's been going off for so long, he doesn't hear the laser beams anymore. But there is less than a few % of kids who just wake up one day and say, I'm just gonna stop going poop just to make my parents mad. You know, like, that's just really not it. And there's just been too much, I'm going to switch the screens back. There's been too much precedent of that this is something that kids are doing psychologically when they're not. There's a physiological basis for all of this that comes out with some psychological control issues because it's a developmental issue. This is all when they're learning how to talk and have expressive language and move their bodies and navigate environments and navigate the sensory world, because people are introducing it around 2, can go anywhere until 5. Think about what else you're expecting a 2-year-old to do. You're still talking, you can't counting their words and language at that point. You're still looking at fine and gross motor skills at that point. Yet there's an expectation to do something that's a very sophisticated physiological process under all conditions, right? And when you first learn to ski, you don't do it under all conditions. You go on a good day to a class, to a green run, and you're good. But you don't then go hit double black diamonds the next day. And if we can start to account for that, toileting incontinence is a physiological process that has to be mastered like any other process, with practice repetitions under different practice trials and accounting for physiological and cognitive skill levels, I think we'll all be in a better place. So let me get back to, and just in case that led to any questions, but it sounds like not. Okay, so we're past constipation. Okay, so just a quick review. Constipation begins for any number of reasons. The colon gets overstretched, encoparesis begins, enduresis may be triggered. It becomes a vicious cycle, especially when you account for the effective Miralax, which is the #1 treatment given, because, and we'll talk more about that. Okay. So, okay, they've come in and we've decided where we're going to start, but how? How did I get there? Like, how did I know that's where I want to start? Well, we do a PT evaluation, right? And I don't know if any of you are familiar with physical therapy in general or physical therapy for children, but these are the general things that we're looking at. We're first looking at the skin and integumentary systems because we need to know if that system is intact, if there's any scarring that may be leading to lack of mobility in the core and the trunk area and the pelvic region. We need to look at posture and breathing systems. This is actually like the #2 thing that we look at after we make sure the skin is intact. We look at muscle strength and activation patterns. We look at neurological control and muscle tone. We look at coordination as a general scheme, and then in the core and more into the pelvic floor. Look at developmental reflexes. We look at regulation, interoception, and a sensory system screen. And I can probably define those more if you need to, but regulation is how you or your child or anybody keeps themselves together emotionally and cognitively when trying tasks. Interoception is your ability to monitor signals in your body. And then your sensory system is, interoception is really part of your sensory system, but it's the most sophisticated. And so the sensory system being, how do you coordinate visual, auditory, vestibular, touch, all those senses? How do we put all that together? PT screens that for us. And then if we need more assistance there, then we refer to OT for a deeper investigation. And then we also do a functional mobility screen. Here's what we find.
Dr. O'Malley, I'm so sorry. Can I interrupt you real quick?
No. Yes, of course.
Are you intending to share your screen, or is at this point the PowerPoint presentation, or?
Oh, it was. Is it not sharing?
Not yet.
No.
Oh,
That's a lot of information.
I am so sorry, y'all.
You are fine.
You're fine.
Is it not? Where is my post? Where's my Zoom? Okay, hold on. I will go back and show those slides again. What? Okay. I just lost my Zoom, like my ability. How am I still here? Oh, maybe this one. Okay. I am so sorry, y'all. Thank you for getting me. It's been one of those days, people. Okay, now now you're seeing my. Alrighty, let's go back. Okay. So again, how? PT evaluation, skin and integumentary, posture and breathing, muscle strength and activation patterns, neurological control and muscle tone, coordination, both full body and in the core, developmental reflexes, regulation, interoception, and sensory system, and a functional mobility screen. Okay. What we see is to significantly altered posture, which is kind of the essential powerhouse to how this is all working. muscle weakness, you know, throughout the body and at the core. Improper toilet positioning, because we do review that, like how are you sitting on the toilet? Is it the right size? Are you able to use the muscle patterns necessary? We also find a lot of retained developmental reflexes. Those are developmental reflexes are things you are born with that help guide your neurological maturation. In the babies, the easiest one you notice is their little fencer's reflex, like around 2 months when they start going from side to side like this. Those are some of the reflexes, that not that particular one, but that is what we're looking at, those kinds of reflexes. Altered interoception, which is, again, people's ability to sense their own signals. So we're finding that for most of the kids, it's less of a physiological issue, as in their physiological system and their sensory system are not communicating correctly. And so the signals are not coming at the right time. We're finding a lot of other developmental challenges. Now, again, some of that is just the nature of what Good Beginnings does. We're known as a sensory clinic and helping a lot of kids with autism. So I think we're also meeting those kids more frequently. But we are finding, I meet a lot of kids who have been missed, that they've got some general issues that need tweaking. And then social and emotional challenges at home. And again, I didn't want to put in all the research. I don't think you guys are looking for the references. I have them upon request, but a significant factor is stress in the home, disconnect between parents, moving, all of those things that change a child's general stability are big factors that are linked. We're just going to talk for 2 seconds about posture, if I can quit hitting this so fast. And this is one of my favorite models of all time. It's called the Can Model of Respiration, and Creighton was kind enough to put it in the literature to get you to come to this talk. I don't know how many people are excited about it, but our bodies are a pumping machine, is how you kind of want to look at it. And our bowel and bladder system is part of a larger pumping machine, almost like a water filtration plant. That's usually the one that I show families and the kids. And there's 4 main components to a water filtration plant, which is the product, okay, the water or what we're filtering, or in our case, you know, poop and urine. There is the alignment or the structure of the building, how the pipes connect together, where the electricity hooks up to it all. And those places all have to be intact and connected for anything to work. That's 2. Then the third one is the power source. So everything can be connected and you can have a great product. If no power is going to the system, then nothing's going to happen. And power for us is generated internally, and a lot of it is what comes from the core, and that's right in all this. And then number 4 is the guy or gal or whomever in the control box, right? So there's somebody who monitors all the pipes and switches and lets you know that there's a problem, or just when you should turn on pipe A versus pipe B. So 4 main components. The Can model does a really good job of showing your body and how we need alignment and power. Okay, I see we're getting close on time, so I want to make sure we have questions. So I'm just going to do this quickly. But your core, this should just represent, your core is way more than the abdominal muscles you think it is. And it actually starts with your vocal cords, and it goes all the way down to your pelvic floor down here. And there's everything in between. So vocal cords at the top half of your trunk is your thoracic cavity, so where your lungs and your heart and your sternum and all those muscles are. Then there's the big diaphragm muscle, the number 1 most important yet underrated muscle in your body, which splits this part into 50-50. And then there's your abdominal cavity, which has all the other organs and your intestines and whatnot. And then the reason I love this model so much is the pelvic floor is the underside of the can. So I just want you guys to appreciate that. Can you see this? Can you see the underside of the can from here? You cannot. Is it touchable or visible from the outside? It is not. You have to get right up and close and personal to that soda can before you can touch the dome. It is a protected area of your body, and it is the same in humans. It is a protected area that is meant not to have easy access, which means it's also not easy to access when you're having challenges with it. It's also not as easy to feel, and you can't look at it. So when you're talking to a child and trying to resolve these issues, it's not the same as looking at their hand and saying, you know, what do you see on your hand? Is it hot? Is it cold? They've got to go inside to have some sort of internal map of something they've never learned before. And all of this around it has to support it. Everything in pediatric development goes from the head to the foot and from the middle to the out. So all of this has to be working up top before you can expect the pelvic floor to do its job. Where I find most of my posture deviations are here, which means your pumping station structure is not supporting your pelvic floor. This is also where you generate force. We don't have time to get into the mechanics of this. We always do it in evaluation, I promise. But this diaphragm muscle, when there's postural deviations, is often put at a disadvantage where it can't push hard enough and it can't generate enough force or push the poop through, which is why you're also getting constipated. So no one should really be diagnosing continence-related issues if you're not looking at the whole body. You can't just look at the colon and expect to get a result. And that's the one thing that we're really working on with outreach is it's not a Miralax and go kind of thing, because the Miralax is way down in here and the rest of the body needs to be active. Okay, that's the Soda Can model, written by Mary Massery, one of the best PTs in the entire world. She teaches this every weekend, everywhere across the globe. And I'm lucky enough to work with her, so I'm supposedly a little biased, but this revolutionized things in physical therapy when she came out with it. Okay. So then what do we do, right? Like, we got to get moving. What do we do for this? Well, if posture is one of the biggest things, we start with postural reeducation. There's something with pressure regulation garments that can help. And that is like, they're little spandex girdles that they make for kids that are real easy and low intensity. You can get them for $21 on Amazon that we add in to help with power generation. We do muscle strengthening to get those individual muscles to not need the garment to help. There's something called standard urotherapy, which is all the other consultation and support on nutrition and hydration and, good bowel and bladder habits, and all of that falls into it. And while we're not nutritionists, we don't do very in-depth things. We can do basic hydration and nutrition requirements. And being that we're pediatric, we also have a great feeding support program, which I jumped to right away. But a lot of times I hear, he eats chicken nuggets and French fries and there's no color in his food. Well, that's not going to give you a very good product. So then we also do have to address the kids that don't eat anything, because you can't just Miralax and keep telling them to push. Like, we've got to do something to change the consistency. So that can be part of standard urotherapy. We can do bladder training. There's wonderful new protocols for interferential electrical stimulation, which is kind of like, if you've heard of TENS or if you've ever gone to an adult thing and you've had an adult injury and you've had to use muscle stim to strengthen the muscles, it's a similar product to that, except it works more at the nerve level. There is biofeedback. We don't do that at our clinic, where you can put electrical stim on the actual, the sphincters, and kids can learn how to play a video game with their bum holes. And it's very interesting work. We just don't have the money to invest in it. And most of the people are not that interested in it. They'd rather try the other stuff first. We do use a research-backed interoception curriculum for the kids who are ready to learn about connecting the signals to their body. We use OT for that. We do feeding therapy. And then some kids who have either developmental issues or just, regulation and sensory issues, you've got to address those before you can really get into the nitty gritty. So those are many of the interventions that we do. Okay. I can't let you leave without reviewing at least how you're supposed to sit on the toilet, especially if you have a kiddo that you're trying to toilet train right now. Okay. This is a standard sitting posture for working at a desk. It is not the same posture you should be using when you're sitting on the toilet. So when you're sitting on the toilet, you should be sitting where your bum fits the opening of the toilet quite well. You're able to flex yourself forward and rest a little bit on your legs. And your knees need to be higher than your hips. So typically needing a stool, unless you're really tall and have long legs. So most adults would benefit from having a stool, because what happens is, this didn't make it onto the slide, there's that big curve at the end of your colon. So right at the end, where it's the hardest to push, you have to get all of this product around this big bend in your colon, which is about 35 to 40 degrees. When you sit like this, it's still curved. When we sit like this, it straightens out. That's why squatting in less developed countries is a really accepted form of toileting, and because it works, right? And so with children, you need to not only make sure their hips are above, their knees are above their hips, but we need to make sure that their feet have support, because you need to press into something to generate force. And we want them to be leaning forward, not back. And we don't want them dangling on the edge of the potty. And the one thing I apologize, I didn't have time to put in the slides, where I found all these pictures of proper toileting, and they're real cute, and it's what most people think is okay. But your kid's just not getting enough support there, and no wonder you're a little frustrated, right? So that's just a general rule of how to sit on the toilet. Then, just to make sure we get to this, I wanted to talk a little bit about toilet training readiness, because that's what most people want to know. They want to come in and they're like, what's the best way to potty train my child? And so I need to be clear right now, as medical practitioners, I don't potty train anybody. And I really have avoided getting involved in potty training in any of my people's kids that I know, because there's two distinct definitions that I hope start to get out there in the world. There's potty training, what we typically think of as potty training, which is typically it's time to take the diaper off for 72 hours and we're just gonna go naked, and every time they have to pee, we're gonna stick them on the toilet, and this and this and this. And then there's toilet training readiness, which is, have you acquired all the developmental mastery of all the things you need to go into potty training, which I use in quotes to kind of show that it's a different thing. Toilet training readiness is the couch to the 5K program. It's your marathon training program that you do for 6, 12, 18 weeks, whatever you need to run the marathon. Potty training is the marathon. Okay. So, and that's why you see that people do it over bulks of like 72 hours to get it started. But it's so rare that anyone learns any skill in 72 hours under all necessary conditions. Even if you are the most prepared grown-up in your entire world, much less if you are a little developmental being who's learning so much about the rest of the world. So what we really like to emphasize is that toilet training is a developmental skill. Toilet training was already, like my little screen here, is becoming more of a challenge pre-COVID. And research is showing significant disruptions in all areas of development post-COVID, which means mastery of continence has become more difficult. Let me see what's over here. I could talk to you about this forever. I'm going to go back. I'm not ready to talk about that. The gist of it is, most of the research that we've been coming up with now is showing you can't show voluntary control of the bladder before the age of 3. Okay, on average, the average child can control the bladder, have some volitional control of the bladder before 3. So again, with statistical reasoning, some kids are earlier than 3, some kids are older than 3. The average is 3. Okay. Years and years and years ago, when development wasn't impacted and babies slept on their tummies and development was different, we could introduce it earlier. That's a different talk that I'm also happy to give on another day. But development has changed because babies are sleeping on their back. And this is one of the things affected, is there's less natural internal mapping of your internal system. And so whatever we did for those of us in the 70s is not necessarily applicable now. But the real reason that most people toilet train around the age of 3 is because daycare likes you to be trained by the age of 3. And I'm not here to knock daycares. That's fine. They're welcome to do what they want to do. Bless daycare's heart. It actually has to do with insurance riders and coverage and things that they need to do so that they can function and be there for you. But the insurance people who made the rule of 3 years old didn't look at toilet training research to see if that's what worked. They also didn't account for the fact of being trained by people who aren't your primary caregivers outside of your home. Okay, so what we've been having for the last decade or so is introduction of a skill that kids may not be ready for an artificial reason, and they might not be ready. And part of the reasons they might not be ready is you need to be aware of so many other things. You need to have language. Oh, this is where we're going to go to this. Sorry, I have a slide on this. Okay. Then there's other complicating factors on top of what I just spoke about. So again, there's the emotionally stressful life events and the fact that psychological status can influence childhood voiding. There's more stressful events. The last 3 years of COVID, the increase in technological reliability, the differences in family parenting and structure styles, and the increased use of outside daycares or caregiver sources, which is, again, there's no judgment on that. Those things affect what you can do. There's things like lower muscle tone, constipation, which we all know is the root of everything, is really caused by or is influenced by a lot of medications, especially ADHD, which has been on the rise, and we're medicating more for that. So 50% of the boys that come in who have significant constipation and issues are already on ADHD medicines as early as 3 and 4. So that is affecting your system, but there's many other medicines that have constipation effects that are very significant. Okay, this lack of interoception, another word that you've never heard of before, but this lack of ability to know your body. Well, one of the reasons you don't know your body as much is because instead of playing with your body outside in the dirt, we are playing on screens. We are playing on two-dimensional surfaces that are being shown developmentally are keeping us out of touch with our body. So what we have to do is, if we're going to keep playing with screens, introduce other activities that make sure we make up the gap for what we were or weren't doing when we weren't using the screen, especially in the land of COVID, where for 3 years, everybody just sat at home. They weren't around other kids. They weren't in a community environment. They weren't playing any of the community games or having conversation or modeling from other kids. We're still really in that after effect. And one of the things we have to make sure is that our programming remembers what we did before COVID, so we can bring those concepts back in. We're also seeing an increase in sensory issues because, again, kids aren't moving their bodies the way they used to and having the experiences that they need. We're finding a lot lower motivation to participate. There's no official data, but a lot of that can come from, again, being at home for 3 years where someone controlled your environment for you. It's really hard to just take that over again, right? It's also hard for us to let it go. But there's also, the advent of screens. Screens pull you in. They don't make you want to go. Interrupting a desired activity to go to the toilet is one of our biggest challenges now. And then there's just altered neurological control. If there's something going on there, that's going to be hard to work with. Okay, so here's the essentials of toilet training readiness. These are the 7 things we need to talk about, be aware of, or work on before you run the marathon, right? So these are things you can start at any time you want to be making sure your child has these preparatory skills to be running the marathon. The first one is, and this is a physiological indicator, can your child stay dry for at least 2 hours at a time? Okay, until they can stay dry for 2 hours at a time, there is not enough volitional bladder control. So there's no point. So you can start timing diapers to see when it's time to get close, and for those lucky people who feel they're doing it at 18 months, I don't know what they're doing. It's fantastic. I'm super happy for y'all, but the research just doesn't support that should work. So I'm happy for the outliers, but you need at least 2 hours, and longer would be better. Can your child dress and undress without help? And I always like to modify this. Can they engage with dressing so that they can be a part of one of the preparatory factors for getting on the toilet? No one is going to be truly toilet trained, if they can't take themselves to the toilet and take their pants down, or tell you they have to go to the toilet, like if they're physically impaired, like children with cerebral palsy learn how to toilet all the time, that's fine. And if they need help with their pants, that's fine, but they need to be a part of that entire gestalty system of these 2 things go together, and this is how I do that. Okay, along with kids that might have physical mobility issues, does a child have enough abdominal strength to sit, stand, and walk? If not, you do have to adapt those things. You have to adapt how they get to the toilet. You have to adapt the time needed to get to the toilet. You need to adapt the sitting support on the toilet. You would never just fling yourself on the edge of the sofa and try and do something. We have to make sure the toilet is as supportive of a surface as anything else. Okay, and these are the big ones that are getting harder nowadays. Does your child notice when their diaper is soiled? They have to notice. If they can't have enough self-awareness to know when they're soiled, they are not ready to do more than that. So please just keep that in mind. It just means your child may not be ready. Then the next level is really, not only do they notice, but do they tell you? That's an extra cognitive step. And again, you can have a child with speech delays or other issues. You can have a child on the autism spectrum. They don't have to walk up to you and say, hey, mommy, I need to go pee or poop. They need to have an indicator, a consistent indicator that tells you when they need to go. It's fine if you're monitoring it for a while. Like I see people who tell me, oh, I can tell when they have to go and I take them to the toilet. That's great. There is a connection being made there, but they're not initiating that. And so if you really want true mastery, they have to at least tug on you to give you the signal, okay? Does a child show interest in using the toilet? So this is one of those where you want to spend time showing them what potties are and reading the books and talking about, they have to just know what it is. It doesn't help if we just constantly take them there and then take them off of it. And we've got to introduce them to the toilet because toilets are scary. And little potties are the better way to do it, but most people just want to use the toilet in their bathroom nowadays. So we need to know how to adapt that, but make noise and get used to noise and go in public where there's auto flushing. It's a whole world of things to learn about that we need to make sure that they've shown an interest in, that they can tolerate it on a sensory level. And then here's number 7. This is the worst one right now. Is the child willing to interrupt a desired activity to use the toilet? This is usually a big sticking point. Well, if she would just stop what she was doing and go, She doesn't have to be in her pants, but she doesn't stop what she's doing. Or I get a lot of, it happens during aftercare at school when they're on the playground, right? Because they're in the zone and they are not paying attention, and then it becomes too late. So these are the essential 7 that we really want to try getting out there as a message. These are things you can start working on at any age. You can read the books, you can talk about things, and once they're staying dry for at least 2 hours at a time, start looking at the rest of this. Make sure they're strong enough, make sure they can, make sure you adapt the toilet, make sure you start working on a language to talk about, oh, did you notice you have pee-pee in your diaper, or you have poopy in your diaper, or whatever, whatever your language is. You have to work out that communication system so that there's really a two-way interaction. And then you can start playing with a potty toilet, and then you can start making sure that they can interrupt the desired activity. And I hope that all makes sense. We're getting close to questions, so that should help. In fact, I think we're right there.
Great.
I tried to have good pictures, but I didn't get to them all. Oh, but 7:56, not bad. Not bad for having to deviate.
No, I think you pivoted really well, and it was great to see that that extra the image, I guess, as I mostly treat adults. I mean, I have treated some kids, but I mean, I think that image was actually really helpful for me, even in sort of helping me treat my adult patients, because unfortunately constipation sort of spans the ages, and one kind of wonders, is it something that starts in childhood and then continues on? So there's a lot.
I think with a lot of adults, what happens is they lose abdominal tone. So even though it's been an acquired skill, and that's from anything from the low back pain we feel to the mobility in your spine. We all start out exercising so well in our 20s, and then life gets in the way and we start adapting. And so I think they lose the ability to generate pressure like they used to. And then the constipation doesn't help. So many of the principles, and again, we can do a part 2. And there's lots of again, this is just the surface, but it does adapt to adults as well.
Interesting. Now, in your practice, I mean, you talked a lot about the constipation piece of it. I mean, obviously that was the main focus. I mean, do you take children who also have an encoparesis, where they're wetting the bed or bedwetting? Is that, and do you find that I mean, you said the constipation is kind of the root of all evil, but what are some of the other issues that could be a cause for encoparesis and like bedwetting?
Well, so 2 different things. So the encoparesis, for sure, you never have encoparesis unless you have a neurological issue.
I'm sorry. I mean, aneurysis.
The aneurysis?
You know what I'm talking about? The pee. I'm talking about pee, not poop.
Yes. Sorry, the aneurysis. Yeah. Sorry.
Yeah,
so yes, we do all that too. So a lot of times you have to clear constipation, because what happens is the bladder and the bowel, like where the constipation tends to get stuck, is right on the bladder. And we teach the kids and the parents that it's a bladder balloon. Right. So it's just like filling a water balloon. And so what happens, between Christy and Ceci, when you put a balloon up to a faucet and you fill it with water, if you don't turn off the water, what happens to the balloon? Right. It goes and it explodes. Right. But in your body is smart enough to not let it explode as a whole function. So what it does is it explodes out the opening. And so it's simple physics. And so we have to. And then when the balloon is really full and the constipation, so here's my bladder balloon, and then here's where the poop is laying, all it takes is a little bit of movement to just press enough on the bladder balloon to let it out. So once we get the constipation clear, then we work on bladder retraining, because that's overstretched as much as anything else and not feeling its signals. So then there's, some of it is just working on like timed voiding, so that we can give the tissue time to reacclimate. A lot of it is timing related things and patterns and systems. So we can work on that. And that's a lot for the daytime issues. And then we do work on toning up the pelvic floor. Like, I don't mean to say we don't do pelvic floor work. We do a ton of that work. And there's home programs that you get, and there's exercises in the clinic. We don't do a lot of stimulation for that stuff. We just haven't found that that's what we've needed. For the people who are releasing when they don't want to release, we've got to tone it up. For the people who can't release, we have to teach them how to let go of their bladder. So a lot of that is breathing and posture and a lot of those exercises. For the nighttime enuresis, and I'm glad you brought me back here, thank you. The research has shown that it's not the same thing during the daytime, and it's due to disrupted hormone levels. Well, there's 3 main reasons. So one is a genetic basis. There's this 15% of genetics where, like, mom was a bedwetter and the kid's a bedwetter and grandma was a bedwetter. And a lot of that is just maturation factors, like they haven't pinned it down, but is it that the bladder size doesn't meet the body size? They're not growing in tandem, so you just don't have enough space in one for the other. And those people, those 15% of people tend to self-resolve by the age of 13, 14. It lasts longer than you want, but it's not atypical to wet the bed at least a few times before the age of 11. It's not atypical. So again, nobody wants it, but that doesn't indicate a big flag. And a lot of those maturation people will then just making sure this is not you, okay, will then mature on their own as whatever in their neurological system catches up. Then there is the two other biggies, which are disrupted sleep or dysregulated sleep. And there's two big ones. There is obstructive sleep apnea. So there's the kids with big old tonsils and adenoids. And they're as obstructed as any older adult who's thinking about a CPAP machine. And that's one reason, because their sleep cycle is interrupted. The other is dysregulated sleep, but without obstruction. So kids with some sensory challenges, those people who can't sleep through the night, who aren't getting into REM. And the reason why is that nighttime control is hormone regulated. A lot of it's antidiuretic hormone and the cycles that go with ADH. And in the kids system, that's, I mean, I guess it's for everybody, but that's what keeps the bladder balloon from exploding, right? So bladder balloons tend to fill between 2 and 5 hours at any time during the day. And then by 5 hours, you just have to go let it go. Well, at night, kids obviously sleep longer than 5 hours. And it's this antidiuretic hormone that tells the bladder it's okay to stay stretched without bursting open. But if you're not in the right sleep cycle, your ADH levels get thrown off and it wants to dump the fluid. It's, for adults, it's very similar to congestive heart failure. That's how they were able to figure this research out. And so what we've got to do is figure out the sleep dysregulation, because you can't stop the hormones from doing what they're doing. So that's for, you know, the other 95% of the people. Then there's a small percentage of people who just have a bladder issue that just can't make it through the night. And there are meds like vasopressin and things like that that kids can take to make it through the night. It's very rare that I'm getting kids on that nowadays compared to these other developmental issues. But you have to go and get the dysregulated sleep. So for the kids with obstructive stuff, a lot of times the minute they go to the ENT, they're all like, oh my gosh, look at this. Take out the tonsils and adenoids and you start working towards it. They start sleeping and their hormones regulate. It's not like the next day, but it's over the next couple months. For the kids with the disrupted sleep, it's harder because there's not a direct cause of the dysregulated sleep. And it's not typically like, I'm not talking kids with like seizures or epilepsy. These are just kids who can't sleep, which seems to be more of a thing nowadays. And so we've got to work on that. Whether, you know, we have a combination of people. There's actually from sleep specialists to ENTs to dentists, and like a lot of oral motor structures. Like if they're not closing their mouth at night, even though they're not obstructed, they're letting too much air. There's a whole different world on that. But the PT doesn't do too much for the nighttime stuff right now, except be the people who like to talk about this and then refer you out and coordinate care. And then there is a dry morning program that we recommend when you're ready, like to help with training, and then we take you through the dry morning program.
Got it.
Does that clear up what we didn't? Okay.
Yeah. I mean, it's complicated. I think you just, you brought up so many issues. I feel like we could have a whole, a whole like year's worth of talks about everything that you shared. But I think we should
to my world.
I know. No, it's just, it's really kind of, you know, amazing. But yeah, so we, let's see here. I think what we could probably do is, I guess we're just gonna have to wrap things up because it's already 8:05.
I'm sorry. I'm so sorry.
I'm thinking from a practical standpoint for our parents or grandparents or whoever's watching, if you've encountered your child struggled with constipation, or you're, have an almost 4-year-old who isn't potty trained, like what their parents that may not know, can you go seek a consultation with someone like you without a referral from a pediatrician? Are most of these things covered by insurance? These are just questions that I've encountered.
No, these are great questions. I appreciate it. Yes, in the state of Virginia, we have direct access, and for the next couple of months, you actually, like within 60 days, we have to get a referral from your pediatrician, but come July 1, we're finally done with that. So you have direct access to reach out to a clinic like mine, or if there's another clinic in the area or if you're calling in from another state or something, you can find a clinic in your area. Good Beginnings is always happy to see you. caveat, we're super busy, so don't be mad that it might not be tomorrow. But we can go ahead and do your evaluation. And again, we don't bring you in to do things we don't think we can't do. So we'll really make sure you get the right resources. Insurance wise, you just have to check with your insurance what your PT and OT coverage is, but it's a standard care under PT and OT. Again, and then we always just start with the evaluation to see where we're at. The average plan, it does take a good year typically to really make progress, because there's a lot of moving pieces that have to come together in sequence as you mature, and like one brings to the next one. So it's not like the same as a broken leg or a surgery where it's 3 times a week for 6 weeks and you're done. It's more of a less intense over time thing. But for people who do the full program and really follow what we're doing, we've seen really good results. It's not perfect, but pretty good.
Yeah. Awesome. Thank you so much. I think
so
we have made it to our time, but that was so helpful. We really appreciated having you. Thank you everyone for joining us. And
thank you so much. I really appreciate it.
Yeah. So we'll hopefully see everyone our next town hall.
Okay. Have a good evening, everyone.
All right. Thank you, everyone.
Bye.
Thank you, Amy.